Good morning, everyone, and welcome to our 2024 Transport Symposium, Advancing Health Equity Research, Building Partnerships Between Academia, Community, and Government. Transport stands for Translational Program of Health Disparities Research Training. Transport is an NIH endowed program focused on recruiting and training underrepresented minority URM, junior faculty, postdoctoral candidates, and undergraduate students from Brooklyn and other communities vulnerable to health disparities. On behalf of the Transport Symposium Planning Committee, including a team from Brooklyn Health Disparities Center, the School of Public Health, the leaders of Transport, and Downstate CME Department, thank you to everyone for attending our 7th annual event. Housekeeping notes include a 15-minute break at 10:45, a 30-minute scholar poster presentation session at 11:45, and a 60, and I think we've reduced it to 50-minute networking lunch at 12:15, and a continued networking session at 2:30 p.m. Our moderators will manage panel questions and audience questions at the end of each segment. Lakia Maxwell and I will be available to you to carry the microphones wherever they're needed. For Zoom attendees, please place your questions in the chat. Detailed bio information on our speakers and panelists is available in our program document, accessible via the QR code in our registration materials. It is a pleasure to introduce our transport leaders, our principal investigators, all of whom continue to make exceptional contributions to our community, to the field of health equity, and to the development of future leaders in this field. 3 of our leaders are Dr. Moro Salafu, Professor and Chair of the Department of Medicine and Director of Brooklyn Health Disparities Center. Carla Booten Foster, Dr. Booten Foster, who is not able to be with us today, but who is the Associate Vice President, Office of Institutional Equity, Associate Dean, Office of Diversity Education and Research, and Professor of Medicine in the Department of Medicine. The 3rd member of our leadership team is Dr. Marcus Lambert, Associate Professor in the Department of Epidemiology and Biostatistics, School of Public Health, and the Associate Vice President for Research Strategy and Operations. Dr. Lambert.
Thank you so much, Dr. Straker. Good morning, everyone. I'd like to welcome you all to our Transport Symposium. I have the distinct pleasure of introducing Dr. Wayne Riley. Dr. Riley was appointed by the Board of Trustees of SUNY as the 17th president of SUNY Downstate University in January of 2017. Dr. Riley is an academic primary care general internist with more than 25 years of progressive senior executive level management, research administration, academic health administration, healthcare management, healthcare policy, biotech, the corporate sector, government sector, advocacy, and organized medicine. Before Dr. Riley's appointment at Downstate, he served as clinical professor of medicine, adjunct professor of health policy at the Vanderbilt University School of Medicine, and as an adjunct professor of management at Vanderbilt's Graduate School of Management. Before his role at Vanderbilt, from 2007 to 2013, Dr. Riley had the distinction of serving as the 10th president, CEO, and professor of medicine at Meharry Medical College. Dr. Riley earned his doctorate of medicine degree from Morehouse School of Medicine, a bachelor's of arts degree in anthropology from Yale University, and a master's of public health degree in health systems management from Tulane University School of Public Health and Tropical Medicine. He also earned an MBA from Rice University, and in addition, Dr. Riley completed residency training at Baylor College of Medicine. In June of 2021, alongside Dr. Fauci and Eric Topol, Dr. Riley was awarded the National Medical Humanism Medal by the Arnold Gold Foundation for his impactful leadership. He's been awarded numerous medals. He serves on numerous boards. He's been elected in 2020 as the chair of the Board of Trustees of the New York Academy of Medicine, whose mission is to influence and encourage action towards improved health of all New Yorkers. And Dr. Riley, in 2020, also began a 3-year term as Commissioner of the United States Medicare Payment Advisory Commission, or MedPAC. There are many distinctions that Dr. Riley has, one of which he is also our president and a transport PI. I encourage you to check out his bio in our book, but I'll turn it over to Dr. Riley now. Thank you.
Thank you. Well, good morning. Thank you for that wonderful introduction that my mother loves to hear. Even at 87, she still likes hearing that about her number one son. So thank you very much. What a great morning it is to welcome all of you to this great transport symposium that is going to do the work of discussing, strategizing, debating how we can better develop our research agenda at this great health sciences university with great community partners to make the daily lives of men and women from different backgrounds better. That's the best way, colleagues, I can elucidate why we're all here. And throughout my career as a general internist and an academic physician, I've always kept in mind that our job is to try to make people's lives better, whether it's the diabetic, whether it's the lady with cancer or the woman with thyroid disease, or the young man who has an early diagnosis of colon cancer. I was telling someone the other day, the youngest person I've ever diagnosed with colon cancer was a mere 29 years of age. And I've never forgotten these points in my career where I said, wow, couldn't we have caught this earlier? Or more germane to what we're talking about now in medicine, is there some genetic way we could have anticipated this 29-year-old developing a very lethal colon cancer? So these are the types of approaches that I hope we will embrace. Thinking forward. Case in point, last night I was at a meeting. You can't go to any meeting nowadays without talk about where can artificial intelligence get us down the road to better health equity. It has the potential to exacerbate health disparities, but it also has the opportunity, if we embrace it, if we study it, if we get the objective data, to really transform the care of Black, minority, brown, and lower income communities. So again, these are the types of exciting things that our team, our colleagues here at Downstate, think about when we think about this great transport grant that we have been so fortunate to have received from the National Institutes of Health. I can tell you, having been on a number of NIH panels in my career, in fact, I chaired the advisory council for the National Institute of Minority Health and Health Disparities, that most people forget was a part of the Affordable Care Act. It was an institute before, in office. But when President Obama signed the Affordable Care Act, tucked in the bill was the fact that it would be elevated to a full-fledged institute at NIH, just like in National Cancer Institute, NIDDK, et cetera. So again, another great piece of work by our great former president, because he understood how important it was to elevate the portfolio at NIH. The residue of that is, of course, that we were successful in getting this grant. And I want to salute Dr. Lambert, Dr. Straker, Dr. Salafu, Dr. Booten Foster, who's not here. They are the dream team. And Dr. Camacho, the dream team. I am so blessed and fortunate to have such passionate, committed, excellent, savvy scientists who understand how impactful our scientific work can be to, again, getting back to where I started, to making people's lives better. So on behalf of all of us who are privileged to learn, teach, work and serve this great university, this great borough of Brooklyn. Thank you for coming. I particularly want to acknowledge the presence of the Deputy Borough President. You'll hear from her shortly. Thank you, Madam. Thank you for being here. And Dr. Morse, our Deputy Commissioner from New York City Department of Health, amongst the other presenters that we're going to have here, because I think this really is a great way for us to contribute and to move the needle for health equity. So thank you very much.
Thank you so much, Dr. Riley. That was wonderful. And now I would like to introduce Alicia Goodrich, Assistant Vice President, Government and Community Relations at Downstate.
Thank you. Good morning. It's hard to follow Dr. Riley because he did everything for me. Thank you. Good morning. This is I believe, my third symposium, and joining this great institution, I'm a student. Y'all will forever be a student. I'm learning every year, and I thank you all for your leadership, Dr. Salafu, Dr. Straker, Dr. Lambert. It's even Dr. Bruno Cardi, just in our conversations of where we can continue to grow. You think you know everything until you walk through the doors of SUNY Downstate. You know nothing because the experts are here and they have the true access to the community. So welcome again to this event that dedicates advancing health and equity through translational research and training. And in my role, representing the institution, the hospital in Albany, DC, but especially the community, my favorite place. It's my honor to extend a warm welcome to each of you and take this time to learn more about the health disparities that we're facing, learning from the experts that are in the room. But I have the great, distinct pleasure of welcoming up our Deputy Borough President, Reverend Kim Council, who less than a year ago, actually, became our Deputy Borough President. It was announced a week ago, last year. I follow you. And we have a twofer because she is the Deputy Borough President, but she also is a Reverend. So she gets it on both ends. And I don't know if you'll see her full bio, but her commitment to people and what made her a perfect choice for this role is because she worked on affordable housing programs, organized food pantries, developed youth enrichment activities, working on violence prevention programs in Brooklyn as the executive director of Berean Community and Family Life Center. Her work spans across the board in Brooklyn. She's a mom. I like to talk about that, especially Women's History Month. We do it all. I have a 5-year-old. I don't know how I'm here this morning. That's a whole symposium in itself. But what I did not realize is that we have the same alma mater. Just like me, she is a reference librarian, and we graduated from Pratt Institute. So we got some talking to do. But hers was in law and I was in business, but we dealt with the same craziness, so she understands it. She is well built to do this job, working in Wall Street. So I don't want to take up any more time because she does have to go to another event, of course, but I would love to have our Deputy Borough President, Reverend Kim Council, join us on the stage. Thank you for your time.
Good morning, good morning. I'm so glad to be here and so sorry that I can't stay because I know that you're gonna have a wonderful program today. This whole setup is really intimidating. I feel like I should be a little taller, Dr. Riley. And want to bring you greetings on behalf of the Borough President, the Honorable Antonio Reynoso, and you know that health disparities is very important to him. As we were running for office together, he talked about maternal mortality, and he put his money where his mouth was, spending all of his capital money in his first year to try to make Brooklyn the safest place for women of color to give birth. And I'm glad that we are here today to talk about disparities in health equities and how we can move the needle forward and how we can work together, both in academia and in the community and government. And I'm reminded of a story. I like to be brief. Blessed are the brief, for they shall be invited back. But I was thinking about this morning, like, what could I say? And I was thinking about this story that Congressman Towns used to tell all the time. There was a young boy who fell into a well. And this young boy fell into the well, and he was yelling and screaming because he couldn't get out. He was down too low. And let's say a professor passed by. The professor had a piece of rope, and the professor tried to put the rope down, but the rope wasn't long enough to reach the young boy. And then we had the local city council person pass by, and the local city council person had a piece of rope, and they tried to put that rope down, but that rope wasn't long enough to catch the young boy. And then a farmer passed by, somebody that lived in the community, and they had a piece of rope. And they were standing around trying to figure out, well, my rope is not long enough, your rope is not long enough, and finally the young boy at the bottom said, why don't you tie your ropes together? And when they tied their ropes together, they were able to get the young boy out. So when we sit together and listen to what each other has to say in our unique perspectives, perhaps we will be able to begin to solve and eradicate the disparities within our health systems, and get rid of the racism that prevents so many of us from getting healthier. Thank you so much for all that you're doing. God bless.
Thank you, Reverend Kim Council. I'd like to reintroduce Dr. Marcus Lambert, who will share further information about transport and our future plans.
Good morning again. I want to tell you all a little bit about transport and why we're here today. So transport stands for the Translational Program of Health Disparities Research Training. And it's a collection of health disparities research training programs. What we focus on is primarily enhancing health equity research infrastructure at SUNY Downstate. And we also focus on recruiting and training health equity scholars. We've trained to date over 100 students and faculty and have reached over 700 members through our research symposia. This is the transport leadership team. Many of you have met already. Dr. Riley, Dr. Morrow Salafu, who's our chair of medicine. Dr. Carla Booten-Foster, who I believe is joining us online, is the Associate Vice President in the Office of Institutional Equity and an Associate Dean in the College of Medicine. Myself and the four of us serve as the principal investigators. We also have co-investigators, Dr. Mohammed Boujadir, who's a professor here at SUNY Downstate, and also Associate Chief of Staff of Research at the VA. Dr. Marlene Camacho Rivera is another co-investigator, Assistant Dean in our Department of Community Health Sciences in the School of Public Health, and the beloved Dr. Straker, who you've heard from already, and Lakia Maxwell, who keeps us all together. I want to also mention, Dr. Boujadir, good to see you. I want to also mention that we've been funded by the NIH for initially $10 million. That happened in 2017. That funds the Transport Symposium. And that initial funding really allowed us to reach the number of students and faculty, the community members that we've been able to serve thus far. Now, last year, we had a renewal to that grant. So we received an additional $10 million, our second $10 million endowment grant from the NIH. And when I told my kids that we received this $10 million grant, because they were with me when we were writing this late nights, their jaws just really dropped. They said, "How much are we getting?" And I said, "0." Because this is all going to the school. It's all going to the community and the people that matter. But let me tell you a little bit about this program. It's called the John Lewis NIMHD, or National Institute for Minority Health and Health Disparities Research Endowment Grant. And as I mentioned, Transport 2 now, which is funded by this grant, is funded by this $20 million endowment. And what does that mean? We actually are required by the NIH to put this money into an endowment. That money grows, and we're able to spend off of the interest of that. And after about 5 years, we hope to be at this steady state of $1 million that will fund our programs, that will help us to recruit new faculty. And I'll tell you a little bit more about some of our plans and initiatives. I think we're really proud to be one of 6 institutions to receive such a unique opportunity. We're in the company of institutions such as Charles Drew, Meharry Medical College, Xavier University, and as you'll notice, many of these institutions are minority-serving institutions across the country. And as I mentioned, to date we've served trained over 100 health equity scholars. When we were writing this grant, Dr. Salafu said, why don't we double that number? Turns out we're going to do more than just that. In 5 years, we have plans to train over 400 health equity scholars and 100 community partners. So let me tell you a little bit about Transport to Aims. I'll be very brief in my remarks because I want to get to our keynote speaker. But our aims and objectives are really focused on 4 areas. The first of which, enhancement of physical infrastructure and space. We need to make sure that we have some space and infrastructure for all of the programs that we plan to expand. And then we actually plan to expand those programs. We're going to expand our research training and career development programs for students and faculty, especially those from underrepresented groups and backgrounds, and especially those from Brooklyn. We're going to strengthen our engagement of community partners in research. And then finally, we're going to grow our critical mass of established health equity researchers and scholars. So aim 1, establish a new Brooklyn Health Institute for Health Equity. And you might have read about this. But let me start by sort of giving you a little bit of context. This is a racial dot map of Brooklyn, New York. So it's kind of hard to see, but each of these, wrong button. Each of these colors actually represents a dot. And each dot represents 6 people. The yellow represents, sorry, I'm having trouble with this one. The yellow represents Black or African American non-Hispanic populations. Brown represents non-Hispanic, Latino, white alone populations. And blue is Asian alone non-Hispanics. And as you can see, SUNY Downstate is situated right in the middle of central and northern Brooklyn area, which is a predominantly African American area. And in the New York City publications, you'll notice from the New York City Department of Health that the life expectancy has really been going down the last couple, this 2020, which I think we all know was the impact of COVID-19. Oops. I guess this is not a pointer like I thought it was. Okay. So 2020, we saw a dip. And then that has been going back up. But what you see from this graph is that the life expectancy at birth for Hispanics has been 81.2 years. For non-Hispanic whites, it's been 81.8. And for non-Hispanic blacks, it's been 76.1 years. And the life expectancy for each of these racial ethnic groups really has increased since 2020, but we have had that dip. And you see the gap between African American populations, which is largely a population that we serve here at SUNY Downstate. And let me make it even more clear for you. Downstate is located right around here, but if you look more in central Brooklyn, northern Brooklyn, these areas have the lowest when it comes to life expectancy at birth, along with parts of the Bronx as well. And just to sort of really bring home the message here, in boroughs of Brownsville, the Rockaways, for example, you see the life expectancy is about 75 years, whereas when you go on parts of Manhattan, for example, on the Upper East Side, you can get up to 89.8. That is a huge difference in life expectancy just for a small radius of New York City. And so we have a sort of responsibility because New Yorkers, as our health commissioner has noted, continue to lose life years and quality of life. And it's due to, why is this life expectancy? It's due to issues such as diabetes, heart disease, overdose, suicide, a lot of things that actually can be prevented. And so we have a sort of job to do at SUNY Downstate, and we've been well situated to do it. About 20 years ago, right around 2004, the Brooklyn Health Disparities Center was founded. It was formed as a novel partnership between an academic institution, which is SUNY Downstate, a community-based organization, which is the Arthur Ashe Institute for Urban Health, and a governmental agency, which is the Office of the Brooklyn Borough President. And it was really sparked by a report called the Milano Report. And this report recommended the establishment of a Brooklyn Institute of Health Disparities that specializes in both research and organizational support. And that was really the impetus for the Brooklyn Health Disparities Center. Since then, we've been continuously funded, and Dr. Salafu really has led us into Transport 1 funding and Transport 2 funding as well. And I've told you a little bit about that. I think we are now at a point where the Brooklyn Health Disparities Center needs to expand. We've been doing research in many of these areas and more here at SUNY Downstate, but it's really not enough to just accelerate the discoveries of these research. We have to make sure that we are tackling social determinants of health as well. Health disparities are really driven by these social and economic inequities. And when you tackle these things at a structural level, you have the opportunity to have downstream effects. And so it brings us to our aim 1, which is to expand and establish a new institute, not just a center, but a broad institute for health equity that's really going to bring together individuals from across sectors of academia, community, government, faith-based organizations, et cetera. We need to come to the table and we need to work together, as our Deputy Borough President reminded us, in order to solve these challenges. And so that's what we're focused on. And so our aim 2 really is to expand our research training programs. We have almost 10 initiatives that are under the banner of Transport. 7 different training programs across each of our educational levels, starting at high school, a program called CHAMPS. At the college level, we've been running a program called Sprinter for college students to expose them to research opportunities. At the pre-doctoral level, we have a program called PACERS, which was started around the time of the pandemic and the social unrest in 2020. We are starting a new program called TRACS, which is going to focus on the medical school level and graduate level. We've received additional funding from the NIH for programs called CREST, which focuses on clinical research scholars, and from the state and HRSA for a center of excellence. We're going to expand the number of trainees that we're funding through those programs. We have programs for junior faculty run by Dr. Boujadir called PRIDE, which has received a perfect score on his grant. We're going to also add to that training initiative, and we're moving into the community with a program called Community Cafes, which I'll tell you about pretty soon. These programs with the asterisks represent new initiatives, but we're also expanding our current ones as well. Aim 3, strengthen engagement with our community partners, especially as it relates to research. So our community engagement initiatives are really vitally important, and it's critical that we do research with communities, not just on communities, not just in communities, but with communities. And that is our motto. And we're going to start with a community needs assessment. Dr. Camacho Rivera and her team are leading this with Lakia Maxwell. And we're really trying to understand some of the challenges that face community-based organizations. These community-based organizations are often a conduit to our community members, and we're trying to strengthen those partnerships and really understand how we can strengthen their capability, especially when it comes to grants, especially when it comes to research and evaluation and community-based participatory research. And then we have a really novel program. It's called Community Science Cafes. This is an opportunity to really engage in a sort of bidirectional space, a collaborative space with community partners, scientists, policymakers on health disparities issues. And one of the main initiatives that we'll start is a 16-week CBPR training program that is specifically for CBOs. The outcomes really are to help them get more grants. This is what we do here at Downstate. We help our faculty get more grants. Why can't we help the community members and the CBOs do the same thing? So we're going to partner with the Arthur Ashe Institute of Urban Health, which is our longtime community partner on this, and really focus on scalability and sustainability. And then finally, we have to have the workforce and the people to do the work. So we plan to recruit new health equity faculty and researchers. Just across downstate in the last 3 months, we've been able to bring on Dr. Victor Polanco, Sharifa Nasreen, Ashley Grosso. These are all fantastic investigators here at Downstate, one of whom is in the College of Medicine, 2 of whom are part of the School of Public Health. We can't take any credit for this, but we're very fortunate to have them as researchers. We'd like to get more like them. So we are on the cusp of really growing. And before I turn it over to Dr. Salafu to introduce our keynote speaker, I just want to acknowledge that I was talking with a colleague of mine, Gabe, who's our research development director, and we were saying how COVID had affected a lot of institutions. Some institutions did not make it out of the pandemic. Other institutions really weren't too fazed by it. They came out looking pretty squeaky clean. Downstate, we really took a hit. And now is our time to shine, because what doesn't kill you is only going to make you stronger. And I look forward to the future, especially with Transport 2 at the helm. Thank you.
Thank you very much, Dr. Lambert, for a wonderful overview of transport. And thanks to all the, MPIs, the multiple principal investigators for transport. It was a lot of work to get this program started. And I'm so happy that, you've outlined a lot of success stories within the program. The principle behind all this work is the, academic community government partnerships to enhance, health disparities research. That is the principle behind the whole thing. In other words, one group alone cannot be successful. You need the universities to do the work of trying to find out the reasons why things are happening. You need a community to disseminate this information and bring in new ideas and new challenges to where the problems are so that the universities can do those research and find the answers. And you need government to be able to create the policies that are required to move the agendas forward. Without government intervention and policies and all that stuff, basically the research doesn't mean anything. You do the research, you get the results, you publish, and what does it mean if it doesn't move the health equity needle to the next stage? So that is why we have transport. Another part of the issue is how do you get as many people involved in the conversation, right? The research is not enough, but in order to push it forward, you need a lot of people to be involved in the conversation. So you have the high school students involved, you have the college students involved, you have the graduate students, undergrad, faculty, anybody that we can get to be able to train, to understand what health disparities is, and to be able to get involved in the conversation. It's where the conversation needs to be so that we can engineer a new system of awareness and then, contribution to health equity, health disparities research, and with the goal of eliminating everything. The ideal state is one day there will absolutely be no health equity issues, and Dr. Michelle Morse will be very, very happy with that, right? There will absolutely be no health equity issues, and we're all, on the same plane for everybody. Anyway, this brings me to my job here, which is to introduce our keynote speaker, Dr. Michelle Morse. She's an amazing academic, and she's an amazing human being as well. I got a chance to work with her in a project, which I'll mention a little bit. But she is just really phenomenal in this same conversation of health equity, health disparities research, training, and trying to get policy into place to make sure that everybody is experiencing the same thing across the board. She had her education at the UPenn, University of Pennsylvania Medical School, and she did her master's in public health at Harvard, Teachan School of Public Health. She has a lot of international experiences. She just told me this morning she did at least 10 years working in Haiti in different capacities, trying to promote health and health equity, health disparities in Haiti. More recently, she was named the Deputy Commissioner for Health for the Center, and also the Director for the Center for Health Equity and Community Wellness at the New York City Department of Health and mental hygiene. She's also the inaugural first chief medical officer for that department. In other words, before she came, there was no chief medical officer for the New York City Department of Health and Mental Hygiene. So this is a big deal. She's responsible, in that role, she's responsible for leading the agency's work in building public health and healthcare to reduce health inequities, guiding the center's place-based and cross-cutting health research, cross-cutting health equity programs, and serving as a key liaison to clinicians and clinical leaders across New York City. One of the programs that I was lucky to participate in with her is a program called CHECW, Coalition to End Racism in Clinical Algorithms. This is very, very big. One of the things that we've done in medicine traditionally is to be able to predict diseases by trying to say if you are male, if you are female, if you are black, you are white, what is your chance of getting disease? All these predictive equations happened in the early 70s and 80s, and it helped the doctors to do some work. Not knowing that there was this structural racism, this institutional racism in these equations that preferentially hurt minority populations. And we still use those equations today. Through her effort nationally, we've now been able to eliminate some of the equations in some of the areas of medicine, like in the area of kidney diseases. So there's an equation called EGFR, in which you input the race in order to predict disease, how bad the disease is in kidney failure. Through her efforts, we were able to eliminate the race portion of the equation. And I have been, a champion of that. I've gone to several hospitals to give ground rounds on why this is bad for our population and so on and so forth. She's been fundamental in, organizing several international programs and coalitions. It's just a lot of things to mention about her. So today, I'm really honored to be introducing you and really happy to meet you in person to present the keynote speech for this 7th Annual Transport Symposium. So thank you.
Good morning, everyone. It's a real honor to get to be here, especially for what is such an important institution within SUNY Downstate. Thank you very much, having the ability to have the infrastructure to focus on health equity and not only research, but also action is just critical. And it's really impressive to see what you all have been able to do over the many years that transport has been a part of your institution here at SUNY Downstate. So I'm going to speak briefly about a couple of hot topics, I would say, in health equity. And hopefully we'll have a little time for questions at the end as well. And again, just really honored to get to be with you this morning. So with that, I always like to start with just some grounding quotes and reflections. And I'm a proud Philadelphian. I was born and raised in West Philly. And I always like to remind myself of the groundbreaking work of W.B. Du Bois, one of the first ever social epidemiologists, someone who 125 years ago, so in 1899, when the Philadelphia Negro was published, was trying to prove something that in some ways we are still trying to prove and clarify today, which is that the health outcomes for Black people in this country are not a result of biology or physiology. They are not natural or normal. They are the result of social and policy decisions and the social conditions in which Black people have been forced to live in this country for over 400 years. So unfortunately, in 2024, we're still proving that point, right? That this is not just biology. This is much larger and upstream. So Du Bois said, the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. And at the time, he knew what the Human Genome Project proved, right? That there was more racial difference and diversity within races, more genetic diversity within races and between races. And at the same time, we know that the experience of racism and discrimination has physiologic effects, right? So there's a lot to unpack there, but it's good to start with where we were 125 years ago. And then I want to talk also about Keeanga-Yamada Taylor, whose work I hope you're familiar with. If you're not, check her out. She's magnificent. She has done a lot of really incredible work, both documenting and supporting the Black Lives Matter movement from a more academic perspective. She said that justice is not a natural part of the life cycle of the United States, nor is it a product of evolution. It is always the outcome of struggle. And I know that Transport's work is a part of that struggle, and again, thankful for everything that you all are doing. So I want to talk a little about the social structural context. I want to talk about some race-conscious strategies that have been previewed by Dr. Salufu and Dr. Lambert already. And then I want to talk about reparations and anti-racism and where we go from here. So what do I mean by the social structural context? I am someone who believes deeply in social medicine as a framework, and some of you may be familiar with the social medicine world. Rudolf Virchow was one of the kind of thought leaders and founders 170 or so years ago. And social medicine is really about the fact that health and health outcomes are not about health care. They are about politics, priorities, resources, decisions. So it's all about the social context, really. And now that has obviously become very mainstream because we talk about the social determinants of health all the time today, whereas even 15 or 20 years ago, we were not. So when I talk about structural, social, behavioral, biological levels of drivers of health and downstream to upstream, I think the conversation we'll have today is really pushing us to get out of that individual behavior blame game that we sometimes fall into, especially in public health. I will admit public health is sometimes guilty of that, and really into, well, what are the social conditions in which people are born, live, and thrive that create the possibility of health or not, right? And what's our responsibility in government, in academia, in the nonprofit world, in the community organizing world to make sure that those conditions change, right? Because we have the ability to make different decisions and choose different priorities. But as was already referenced, I also always like to think of this with an internationalist framework. It's not just about Black people in America, for example, or Indigenous people in America, or communities in the US that have been marginalized. This is connected to a much broader system of decisions, priorities, policies, and resources. And colonialism and wealth inequity today are still very, very clearly connected to the health outcomes around the world. So I consider myself someone who pushes for global health equity, not just health equity here in the United States. And even though in the United States this very dark green, meaning that we have some of the highest wealth per adult in the world, it masks the racial wealth gap that I'm going to talk about in a second. And at the same time, if you look at health outcomes around the world and look at the patterns of colonialism and wealth extraction over the past couple of hundreds of years, you see that the colonial powers have the highest wealth, right, still to this day in 2024. And the countries that were colonized are still experiencing the systems and economic structures that lead to extraction of wealth, and their health is unfortunately resulting and following these wealth inequities. So on the continent of Africa, you'll still see to this day some of the highest infant mortality in the world. Sierra Leone, highest maternal mortality in the entire world, right? So the legacy of colonialism and wealth extraction is alive and well and influences health patterns around the world. We can never forget that, particularly in Brooklyn, where we have an incredibly diverse community of immigrants from all over the world. But let's come back to the US and responsibility for our own challenges in our health system and remind ourselves that amongst wealthy countries across the world, we are an outlier. The United States remains an outlier. I see a lot of head nodding, so I think you're familiar with this, right? We spend a lot of money on healthcare. We have the lowest life expectancy of all wealthy countries in the world. And we also do not invest in the social needs of our communities being met. And again, that's what Du Bois was talking about 125 years ago. So specifically, I think there's a lot of emerging research on health and wealth, and some of you may be familiar with this. We had the honor at the New York City Health Department to collaborate with the Federal Reserve Bank of New York to put out a white paper last year describing the drivers of wealth and health inequities, and specifically also the Black-white racial wealth gap. What we know from research, and I will also just acknowledge that this is an emerging area because of the work of many economists like Sandy Darity and Derek Hamilton and so many others, but we actually look often in public health and healthcare at income and health. But we don't have a lot of data, we have very little data on wealth and health. And the difference is significant. Income, of course, is your annual income. Wealth is the net sum of your assets minus your debt. And the reason this became a big issue for me is in Boston, where I lived for a few years, we saw that the average wealth of a white family in Boston was $247,000. The average wealth of a black family in Boston was $8. And that difference is profound, but also has a different kind of impact on health than income, annual income might. So encouraging you and transport to delve deeper into this because we need more research clarifying not just income and health outcomes, but wealth and health outcomes. But what little we do know about the relationship, wealth is protective in terms of medical care, in terms of living in a neighborhood with fewer environmental hazards, in terms of having higher quality insurance, whereas debt is associated, unfortunately, with anxiety and stress, not surprising to anyone, foregoing preventive care, using emergency care for treatment, and then also it's associated with poor child socio-emotional well-being, which, you know, again, not surprising patterns per se. But what you see on the right is a bar graph really describing specifically what is the racial wealth gap in this country. As I said, there aren't enough data sources, but this is from the national SCF study that is calculated annually. This data comes from the Federal Reserve Bank, and there's on average an 8 to 10-fold average difference between the wealth of a white family and a black family, and slightly less, but still significantly different for white families compared to Latino families in the US. So we've got big challenges. And then Dr. Lambert already alluded to this, but what I really want to highlight here is that premature mortality in New York City is a major issue and that we suspect it's related to wealth. We're going to be putting out some data later this year looking specifically at wealth and health in New York City. And what I want to highlight specifically in this graph, premature mortality, that's dying before the age of 65, which I think we can all agree is something that shouldn't happen, right? We see here that Black people, long before the COVID pandemic, had a significantly higher rate of premature mortality than every other racial and ethnic group in this city. And of course, it got worse during the COVID pandemic. So again, back to Du Bois, this is not natural. It's not physiological, it's not biological, it's also not the failure or fault of Black people. This is because of our societal decisions, and it's part of the reason that I'm in government, because government has a magnificent, profound, and serious responsibility to address these kinds of issues specifically. So with that in mind, you're probably also thinking, well, so how do we even understand why premature mortality for Black people is so much higher in the city, country, et cetera, than it is for everyone else? And I want to also acknowledge that the data I'm presenting doesn't focus enough on Indigenous people in New York City. I want to make sure that that is clear. Even though we have the largest Indigenous population of any big city in the country, our data is very much lacking when it comes to the health of Indigenous people. Another area maybe for transport to explore. But what I do want to say is critical race theory is an area, a framework, a theory that can help all of us really dig into why these differences happen. Now, critical race theory has been politicized and, kind of dragged through the mud for a number of reasons, including the fact that there is a massive backlash against the health equity movement in the United States right now. And at the same time, I want you to know that this is a very, very powerful theory that dates back 6 decades that was developed by leading legal scholars, including the first ever Black law professor at Harvard Law School, and Kimberly Crenshaw, who you're probably familiar with. So this framework helps us to understand why is it that the life expectancy and premature mortality of Black people and other marginalized people of color in this country is much lower than everyone else's, higher. Social construction of race, again, being one of the critical ways that we in public health and healthcare need to understand these differences. I do think that intersectionality is another one that I'd love to come back and talk about at a future date, but I just want you to not be shy about using critical race theory as a theory to help interrogate these racial differences in health outcomes. And specifically, applying critical race theory to public health, our colleagues Chandra Ford and Collins Irambua developed public health critical race praxis. And I love that it's praxis, right? The praxis means the continuous cycle of education and action. And the reason I love that it's praxis is because it's both a research framework for further interrogating and upending the racial inequities in health outcomes, but it's also about action. And that is what we need, right? And I'm going to talk about some specific actions right now because we have an action gap. We have an action deficit. We have an implementation gap when it comes to health inequities. And I would encourage Transport, again, to really delve into the action side because we know what the problems are. We have a very deep understanding and research about what health inequities exist. So what do we do about it? Here's a couple of examples of what I would suggest we do about it, and this is what we're trying to do at the New York City Health Department. I'm going to talk through 3 brief examples, and I'm going to wrap up in the next 10 to 15 minutes so we have a minute or two for questions. So get your questions ready. You all remember very well May 2020. I'm taking you back in time, almost 4 years ago, at the height of the COVID pandemic here in New York City. Emerging patterns were very, very obvious that Black, Latinx, and Indigenous people in this country and in this city were having the worst impacts, the most inequitable, unjust, avoidable, preventable outcomes from COVID. Whether you're looking at infection rates, hospitalization rates, or death rates, Blacks and Latinx people in this city were impacted disproportionately. And so what are some of the ways that we can actually interrupt that? Well, when therapeutics became available, it was very important for us to say, well, how can we make sure that what we know is a gap in access and disproportionate impact for communities of color actually be addressed when we have new therapies like molnupiravir and Paxlovid to actually treat COVID? So New York State's health commissioner at the time said, actually, you can use Black and Latinx race as social factors to prioritize who gets treatment. This was at the time when Paxlovid first came out. There was very limited supply. I want to highlight that because that might sound hard to swallow, or it might sound like something you don't quite understand, and yet that is a race-conscious strategy for addressing the unfair impacts of COVID on communities of color. Again, not for biological reasons, but for social reasons about access, about, ability to pay, about being able to even get in to see a doctor and get prescribed a new treatment like Paxlovid at the time. And at the same time, what we saw, and I know you all were very much a part of this, we saw a huge gap in vaccination rates. This, again, taking you back to 2021, this is 2021 data. We saw in the summer of 2021 that even though the vaccine for COVID had been out for about 6 months, we saw far less vaccination rates for Black people and Latinx people in New York City. And as you see here, this map, this heat map that you see on the right, with dark blue being the neighborhoods with the highest rates of vaccination, is the inverse of the heat map that Dr. Lambert just showed earlier, right? So the more kind of wealthy and well-to-do neighborhoods across the city had higher rates of vaccination. So we had to come up with some solutions to this, right? And this is not about Black or Latinx people having, being a problem. There was a lot of narrative out there, if you remember, that, why don't the Black people just get vaccinated? And we do that victim blaming all the time in public health. And we have to really change the narrative and change our frameworks for it. So in the New York City Health Department, what we decided to do was say, actually, that's not what's really happening. What's happening is that these are the communities that have had bad experiences in public health, have been mistreated, and often don't have access, either because they don't have insurance, they're working jobs that makes it difficult for them to go get vaccinated. There are a number of reasons why the access and the interest are different, and it's not their fault. So what we need to do as government is actually invest, prioritize, and resource the communities that have experienced disinvestment over many decades, many centuries in this country, and do it through community health worker programs and community-based organizations. So we partnered with over 100 community-based organizations to launch Public Health Corps. We invested about $100 million in the first 2 years of the program to ensure that those community-based organizations were able to train and mobilize community health workers to get the information out there. You remember how hard it was to get reliable information about the COVID vaccine or even know where to get vaccinated. So Public Health Corps was our partial answer to that problem of both race and place-based inequities in COVID vaccination and the disproportionate impact of COVID on communities of color and in disinvested neighborhoods. So what were the results? The results are ongoing. We're actually still, Public Health Corps still exists. We're now shifting it to focus on chronic disease in addition to respiratory viruses, COVID and flu. But what we saw here was a significant improvement in vaccination rates in the neighborhoods that had lower vaccination rates, and specifically amongst Black and Hispanic New Yorkers as well. We were able to show over 700,000 engagements just in our first year with community members, almost 2,000 trainings for community-based organizations, 230,000 plus referrals for vaccination. And again, this is just in the early years. So again, this is a place-based and race-conscious approach to addressing the inequities related to COVID. So here's another example of a race-conscious strategy for action on health inequities. Dr. Salifu mentioned this calculation, estimated glomerular filtration rate, EGFR, that we do to be able to calculate kidney function of people across the world, actually. And this calculation, there's two versions of the equation. Both of them use a Black race modifier in the calculation. What does that mean? It means that every clinician who's ordering a kidney function assessment for a patient has to decide and dichotomize the person in front of them and say, is this person Black or not Black? Because I'm going to calculate their kidney function differently if they're Black or not Black. Now, as you know, the world does not divide easily into Black or not Black, right? Where would Barack Obama fall, right? Because he, is mixed race, but in American society would be classified as Black based on how he looks. How would you calculate his kidney function, right? And interestingly, that original study that came out in 1999 only had 197 Black people in it. And this became national policy. In fact, it became a globally used equation. And Black race was classified based on the study personnel. It wasn't even a self-identified race. And yet it became, the foundation for a calculation that we use 1 million times a day in clinical medicine and has caused significant challenges. Now, how did the study personnel at that time justify the use of Black race in this calculation? They said, well, there's this theory that Black people might have higher muscle mass, and they cited these 3 poorly done studies that don't prove that point at all. And for those of you who know the history of medical racism in this country, you know that idea that Black people might have higher muscle mass dates back to white male physicians in the 1800s who were trying to justify enslavement of Black people and wanted to make the case that actually, no, Black people are totally well suited for enslavement, and this is totally fine. So this is a problem. And it's a problem that has very clear solutions, and you all have been a part of that solution. What's clear also is that there are massive racial inequities in the incidence and prevalence of chronic kidney disease and end-stage renal disease amongst Black people, and this calculator actually contributes towards that trend, right? Because ultimately what the Black race modifier does in that calculation is it makes Black people's kidneys look healthier than everyone else's for the same measured value of kidney function. So that's a problem, right? And ultimately, because of all of these challenges and changes, I had the opportunity to be a part of an effort at the Ways and Means Committee to demand that all the professional societies re-examine how they're using race in calculations of various types of clinical algorithms. The American Society of Nephrology luckily supported really re-examining the use of that Black race modifier and agreed to change it. They developed a task force that set new guidelines to change this calculation. I have the honor of co-founding an organization called Equal Health about 14 years ago, and we, for the past 6 years, have been leading a global campaign against racism. Our chapter in Nashville, back in June of 2020, worked to get this change to happen at Vanderbilt University Medical Center. And Vanderbilt, believe it or not, or maybe you are not surprised, was one of the last medical schools to integrate. And so to have them be at the forefront, them and many other institutions at the forefront of making this change was a very, very big deal. But medical students and trainees across the country were really the leading edge of this movement to change these algorithms. And look at this, talk about action. Within 2 years of the task force's recommendations and these letters inquiring to the professional societies about how they're using or misusing race, a new equation for calculating kidney function was published in the New England Journal. I believe SUNY Downstate uses the new equation now that doesn't use the Black race modifier, and it is just as effective in estimating kidney function. So look at that. Change is possible. And what we said in the New York City Health Department is we can't wait 10 years for this change to go from research into mainstream practice, right? You know that it often takes about 10 years on average for those changes to happen. We said, well, how many Black people's kidney function is going to be affected if we wait that long? So we started a coalition that Dr. Salifo mentioned, a coalition to end racism in clinical algorithms, looking at both kidney function as well as vaginal birth after cesarean section and lung function testing, all of which use a Black or Latinx race ethnicity modifier in a way that assumes that racial inequities and outcomes are normal when they're not. So these are the members of the coalition. We put out our inaugural report back in 2022. And just want to underline, and I'm going to speed up a little bit so we have a couple minutes for questions. Our inaugural report showed that there were lots of things that facilitated these changes, including strong senior leadership support. And I know that you have that here, and I know that you need to continue to invest in both the trainees getting to really help to lead the way when it comes to institutional change, and finding lots of different platforms to have this conversation with faculty, students, and trainees. I'm going to skip the piece on VBAC, even though Black maternal mortality in Brooklyn is a crisis. As you know, it's the case across all of New York City. We have serious work to do, and I know that there are magnificent, magnificent needs for investing significantly in addressing Black and infant maternal mortality, Black maternal mortality and infant mortality here in Brooklyn. I do want to just spend 2 minutes on an example from the institution I came from, Brigham and Women's Hospital in Boston, on heart failure. Heart failure was an area that we decided to focus on when I became co-chair of the Health Equity Committee for the Department of Medicine at Brigham back in 2017. And we said we need an example of ways we can do better at health equity at Brigham that happens within our walls, not something that's abstract and happening outside the hospital. And so we looked at heart failure because we have a center of excellence of heart failure, and it's the most common admitting diagnosis in the emergency department. We looked at 10 years of data, over 3,000 individual patients, and looked at people who came into our emergency room with the primary diagnosis of heart failure. And again, this is another example of a race-conscious health equity action that any institution can take. So the data showed us exactly what we thought, that about 2/3 of heart failure patients who were white went to the cardiology service, which is a specialty service, and only about half of Black and Latinx patients with heart failure went to the cardiology service. Cardiology being the service that has specialty physicians, specialty care, and have very high quality heart failure care. We wanted to understand why that was happening, so we surveyed the emergency room doctors, and they told us that white patients were more likely to advocate for themselves to go to the cardiology service. So this is a way, again, that white privilege becomes an example of institutional racism, right? When white patients' preferences are centered and they get to choose where they go and what specialty care they access. Patients do feel discrimination. And I can imagine what it might have felt like for a Black patient with heart failure in our emergency room to be told, sorry, you can't go to the cardiology specialty service, right? But these are the kinds of things that happen 1 million times a day across our country, and again, that we have a responsibility to act upon. So what we did at Brigham and Women's Hospital, me and my colleague, Dr. Brown Wispelway, developed a framework called the Healing Arc Framework. It's a framework that I would encourage transport to use and look into as well. When you uncover an example of institutional racism, and they abound, we know very well Brigham and Women's Hospital is not the only place that has examples of institutional racism. I would argue that just about every institution across the nation has examples of ways in which they prioritize care for white people and deprioritize care for people of color. So with that in mind, these steps in the Healing Arc model and framework of acknowledgement, redress, and closure are necessary once you uncover examples of institutional racism, that you actually do something about them, acknowledge them, find the actions to redress them, and then closure. So what we did at Brigham and Women's was we developed a best practice alert in our electronic medical system. We understand actually this is the first time that an EMR best practice alert has been used for a racial equity or health equity project and focus, which tells me that we have all these tools to improve care and we're not using them to improve health inequities, and that is a problem. But what we've been able to show actually, and you'll see the data published at some point in the next year on this best practice alert has completely changed the pattern and has had profoundly positive impact on access to care for Black and Latinx patients for cardiology. We received tremendous backlash against this work that culminated after about a year of attacks against us, culminated in neo-Nazis marching on the lawn of Brigham and Women's Hospital 2 times in the winter of 2022. There were over 30 articles in right-wing media calling us racist for doing this work. And unfortunately, that is the state of our nation right now. We did, of course, receive a lot of support from the Global Campaign Against Racism and Equal Health, and many of you in the audience as well, to say, keep going. If your enemies are neo-Nazis, you're doing something right. So with that in mind, what about reparations and anti-racism? And this is my last couple of slides, and I think I might only have time for one question or two, but really look forward to your questions. You, I'm sure, are familiar with Dr. Bassett and Dr. Galeo's work on the health case for reparations, with reparations being payments to Black American descendants of enslaved people in this country to atone for the history and legacy of the racial wealth gap and enslavement over many decades in this country. We also saw, after the murder of George Floyd and during the COVID pandemic, a massive increase in resolutions declaring racism a public health crisis, including this New York City Board of Health, which published its statement and passed its resolution on racism as a public health crisis in October of 2021. And what Dr. Wispelway and I also think is important is to say that anti-racist institutional change is essential to supplement federal reparations. If we're serious about achieving equity now and after federal reparations are paid, we also must pursue institutional action. And then finally, I just want to go back to that original kind of framing around wealth and the COVID impact. And I participated in a study that modeled what would have happened in the COVID pandemic if we did not have a racial wealth gap. If reparations had been paid prior to the COVID pandemic, what would have happened? And our model showed that COVID transmission would have been 30 to 68% lower than it was. Right? So again, actually centering the margins and addressing racial inequities benefits everybody. So with that, I believe there might be time for 1 or 2 questions. I'll just stand up here in case you have any, and thank you again for inviting me.
Does anyone have questions? I'm ready to run the room.
Dr. Morse, very nice, very inspiring. 2 questions. What is public health doing to improve the empowerment of Black and brown individuals as they interface with these systems that are really designed to work against them? That's my first question.
Mm-hmm. You can give them both because we're so short on time.
Okay, so my second question is thinking toward the future, and I do a lot of reading on planning for the future and what futurists think. One of the things that one of the leading thinkers around planning for the future, Joel Barker, says is that in order to really understand what we need to do going forward is to think about what's impossible today, but if we could do it, would fundamentally change things to make things better. And I guess my question is, how much is public health asking those types of questions and in building consensus, or asking that question often and also building consensus around those questions, or that question?
Thank you for that.
Okay.
I think I would say that the discipline of public health and the practice of public health practitioners learned a lot during COVID about both the ways in which the history of public health can sometimes focus on control, especially disease control, instead of care, support, repair, restorative justice. And that, goes back to colonial medicine. It goes back to a number of different histories. What I've seen at the health department is, in particular, because of the existence of the Center for Health Equity and Community Wellness, there's a new kind of conversation happening around the responsibility public health has to support, partner with, and follow the lead of marginalized communities. I would say that Public Health Corps is one of our attempts at really operationalizing that, where the majority of the community-based organizations we funded were led by people of color, employed people of color, and we're focused on, again, the races and places that have experienced marginalization. We have more to do. We have a lot more to do. And I think that's both in New York City, nationally, and globally. And then for what's impossible, I will say, the more public health learns about the history of this disease control past and how it relates to colonial medicine and so many other things, the more likely we are to move out of that pattern of implementation and intervention and into one that, again, follows the lead of marginalized communities and actually develops and launches policies that are about repair and restorative justice. So I'm hopeful, even in a time like this. Thank you again for having me.
I will ask one question.
Thank you, everyone. At this time, I'd like to introduce Lakia Maxwell, who is the program manager for transport.
Good morning, everyone. I'm excited about today in the room of public health professionals talking about this topic and having this discussion. So at this time, we will move into our panel discussions. Today, we will have 3 panel discussions, but right now, we are moving into our academic government panel discussion. At this time, I would like to invite Dr. Daniel Ehlke to the stage. He is the Associate Professor of Health Policy and Management at the School of Public Health at Downstate. Thank you, Dr. Ehlke.
Thank you very much. It is an honor to be here today, an honor and a privilege, and especially to follow Dr. Morse and her terrific work, research, and wisdom today. At this point, I'd like to welcome up to this table the other members of our panel, those of us who are here in the room, and that would be Dr. Azure Thompson and Alicia Goodrich. So if you'd like to join me up on stage. All right. Wonderful. I just want to say a few words by way of preface today. First of all, it's also an honor and privilege to be joined by 2 of my Downstate College colleagues here at the table. We also have joining us via Zoom today Louise Square from the New York Department of Health. Oh. Excellent. Wonderful to meet you. Great. Very good. We're all in the room here. This is terrific. Again, Reverend Counsel sends her regrets. She had to leave a little bit early today. She was initially planning to be a part of this panel. And one other person I want to recognize today, and this is precisely because of something Alicia said a little bit earlier. She's the mother of a 5-year-old. I am the father of 5-year-old twins. And the only reason I'm able to be in this room today, they have the day off for reasons I'm not clear on. It's not their break. They have a day off. I don't know. But the only reason I'm able to be here in the room today is because my wife, Amy, was able to take time off of work for this. So I want to recognize her today as well. Very good. Right off the bat. All right. This panel is going to be focusing on the intersection, the nexus between the academic enterprise and government. Too often, these are considered to be two very different spheres, very different worlds, and it's really part of our job to make sure that we build bridges that cover that gap. I'd also like to make the contention, however, and I want to see how much you agree, disagree on this point, that these worlds are closer together than we often make them out to be. We are all political creatures, and I hope that is not too controversial a statement. I want to start out by saying that there's a classic definition of politics, and politics, a sage once said, is nothing more than the authoritative allocation of scarce resources. And I think by that definition, many of us are engaged, are immersed in certainly allocation of resources. Our level of authoritativeness may vary, but certainly we are all part of that enterprise. And much of what we are concerned with in public health is about how best to allocate those scarce resources given nearly infinite need. And so it is absolutely imperative that we all work together as much as possible and acknowledge the fact that we are all in this together to a very large extent. So I want to start out today, and don't worry, I previewed this with the members of the panel, but I want to start out today by having them tell you a little bit about their own activities, their own history at the nexus between government and academia, and perhaps touching on again some of those commonalities, and we'll then have a conversation to some extent. Hopefully it'll kind of develop organically, but I also have some questions that I'll pepper in throughout, and hopefully we'll ask questions of each other maybe as well, and we'll have some time at the end for audience Q&A as well. So that's a bit about how this panel will proceed. So without further ado, I think I want to start out at the end here with Louise. If you would maybe get us started off in that regard, and then we'll just move on down the line, I think. Sorry. Yes, absolutely. So we have at the end here Louise Swear, who is the Health Equity Coordinator with the New York Department of Health AIDS Institute. And for their full bios, you can look in your program. We invite you to do so. So Louise, very nice to have you here with us today.
Thank you.
Thank
I'm
you.
sorry for the surprise. I was able to attend at the last minute. Again, my name is Louise Square. I work for the New York State Department of Health as opposed to Dr. Morse, who works for the New York City Department of Health. But I've been in public health for 35 years. And I started at the New York City Department of Health, and I think in terms of the nexus between government and academia, there's always been that kind of push-pull, sometimes collaborative efforts, sometimes opposing thoughts about how things should be done in public health. But at the very core of the work, there's always been that need for collaboration. And we do, thank you, and we do try to collaborate to get the work done.
Absolutely. Thank you very much. Appreciate that. We'll next move on to Alicia Goodrich, who you've been introduced to already.
Yes.
Say a few words about your experience in that regard.
Well, my experience is interesting because I'm not a public health expert, but in my work in the last 7 to 8 years, leaving corporate, teaching for 2 years in the DOE, then working for the New York State Assembly, and really understanding where government fits into the community and what they can and cannot do, and understanding that the community's voice is so powerful if they only knew how to use it, and then coming to Downstate, and it kind of completed the circle. I thought I knew everything. Very active in the community before. As a young child, I was a child in the room in the back while my mother was fighting to open schools here in Central Brooklyn as a parent and PTA president. So we have to know our power from that point. and bringing that, it doesn't just start at academia, it starts from kindergarten and works its way up. And when I got here, I coined a title for where we sit as the health and education corridor. If you start from Flatbush, Parkside, Lenox, Clarkson, all the way to Utica, we have everything from life to death. Hospitals, we have the medical examiner, we have a college, we have a high school, I mean, across the board. So if we knew what we could do with this corridor, they wouldn't touch us. So we have to create our own inner district and really strengthen all those pieces. That's why this is so important. We definitely need to advertise more to get our young people in the room, make this something credit-worthy even for our high school students. So there's partnerships with School of Public Health over in the high school in Wingate campus, what Dr. I'm blanking on her name, is doing, but I can go on and on. So I am very passionate about connecting the two, because if we connect the two, they can't remove us.
Absolutely. Thank you. About tying those ropes together, right? As we heard.
That's right.
Absolutely. Absolutely. All right. Finally, last but not least, Dr. Asher Thompson is a professor here at the School of Public Health in our Community Health Sciences Department, also in Health Policy and Management as well. So.
What's the question again? Repeat the.
So basically, your experience kind of at the intersection between.
Yes. I just wanted to make sure that I addressed the prompt or the question. So I'm going to be really drawing on a recent experience with a grant-funded project called Health Data for NYC, which was funded by Robert Wood Johnson Foundation, and that grant project was to bring academics and government together. So it was a lot of funding and it was a lot of work. So for the principal investigators of that project. So I'm really going to be drawing on that. And that particular project maybe started a few months before the COVID pandemic. Okay, so we initially met in person, and then everything went remote. So we experienced the COVID pandemic as well as the George Floyd reckoning, the racial reckoning around that. So there was a lot of activity, and the focus of this particular grant was around health equity. So there was a lot of things that were happening with employees at the Department of Health, with our focus, and just, so I'm really going to be drawing on that and the different ways our institutions responded. I also worked for the National Center on Addiction and Substance Abuse, which was a policy advocacy organization. We also did a lot of research, a lot of advocacy, and to some extent some direct service. But it was founded by Joseph Califano, who was the Secretary of Health, Education, and something else. They split those departments apart, but really drawing on that and his level of access and influence to, I guess, government organizations being outside of that organization. And I do want to finally say I'm going to also be drawing from my family's experience. My father and grandfather both worked for government, one at the federal level and one at the county level. So drawing on these stories of working in government and the way they tried to change things inside and the pushback and struggles that they experienced, as well as them pushing government externally. So both being, that family lore of being inside government, but also advocating for government to do better, to do different. So those are kind of the experiences that I'm drawing from.
Wonderful. Wonderful. Thank you very much. So in terms of starting off with the questions, we were talking at the outset about the fact that, very often there is a gap, there's a chasm, or thought to be a gap or a chasm between the two. So what would you say in your experiences is the greatest challenge when it comes to just bringing together and keeping together, maintaining the connection between those on the academic side and those in government? What is keeping the two sides away, as it were, at points when maybe they should be collaborating?
I'm going to jump in on this one. Because I am not a doctor, I just play one on TV. You got it, so a couple people got that one.
Yeah.
I will always bring a little laughter into the room, but working with BHDC and understanding the importance of our students getting a civics lesson. We have to have a holistic model of, we could be in the books, we could get the practice as the resident. And like I said last year when I opened the Transport Symposium, our people have to step outside the building. And we have to have the conversations. And we have to know who we are dealing with. We have to be culturally, I'm having a blurb here, competent, because Central Brooklyn is the best place you can be because it is truly the melting pot of the world. Over 200 languages, cultures, you name it. We're sitting in Little Caribbean, but you can still walk down the block and hear someone speaking Urdu. So there's always that space of not just the medical piece, but also understanding the community that you serve. So that when you walk out and you end up in suburbia, that's great, but you have that experience. So if someone else other than who you see in that room comes in that you regularly see, you're able to not miss what their needs are. So I think that's the biggest thing, that there needs to be some type of civic training, and I know we're going to work on that with the BHDC in their summer program, bringing in, I already inducted Kim Council to come back, the Deputy Borough President, because they need to understand how it connects, and then vice versa. When I go to Albany, DC, and I'm speaking to our elected officials, there are now everyone running with maternal health, mortality, but Deputy Borough President brought that up. He ran with it because he's a father. He gets it. He covered Woodhall. We know the stories of Woodhall. So he had his children there. So he knew it was about personal experience that got him there. So we have to not say give everyone the experience so they get it, but be able to advocate and share the stories and allow that everyone understands on both ends. So when we come to the table and ask for something, it's not a long ask. They know what's going on. So I send this event to every elected official office in Brooklyn, in New York, so they know, come out, send someone. Everyone's health policy person should be here in this room or logged on. Email me if you are logged on as well. But that's a part of it for me.
For me, there are a couple of different ways that question can be taken. Because when you talk about government and academia, what government are you talking about? Are you talking about public health? Are you talking about what my colleague just talked about? So in public health, we are part of the communities. We, especially in the New York City Department of Health, staff are required to live in New York City. So they're part of the community. They see some of the things that we go through. They experience some of the same things. But in terms of keeping, let's say, public health and academia together, I would say that a lot has to do with, and I kind of have to tread lightly, but I want to lean on what was just said, because you do need to talk to the folks who make the decisions about where the money goes. And I say that because in public health, we are kind of directed by our funding streams. And our funding streams are restrictive. So as you mentioned, I work for the AIDS Institute. I have a little bit of latitude because I do health equity, and health equity should touch everything we do in public health. But if we were going to be strict about it, then generally speaking, my health equity efforts would be towards people living with HIV and AIDS and the other disease entities that we deal with at the AIDS Institute. So think about that and think about what you're asking for when you talk to the people that you need to talk to about where the money goes, where the funding goes. Because it's not that we in public health don't want to work with academia and we don't want to work with community. we have to go where the money goes. Now, that being said, I would also say that, I'm going to lean on my sister here, we need to broaden the conversation, because we talk about health equity, we talk about social determinants of health, we need to talk about the political determinants of health. The politicians and the people who make the decisions about how we're funded, how the programs that we need in the communities are used. There are sometimes, I don't want to say restrictions, but there are guidelines, strict guidelines given on how we're supposed to operate. And so all of you have a hand or have an opportunity in talking to whoever you need to talk to, whoever that person is in your community that represents your community in government. You have an opportunity to talk to them about what you need, what you want, what is necessary for your communities to thrive. So that would be my answer to that question.
Thank you. And it occurs to me that, it's absolutely essential, I think you both touched on this, that, both within academia and really out in the broader community as well, there is a greater recognition, a greater awareness of where that power resides, where the levers of power are, and how best you can push on those levers of power.
Exactly.
It's not obvious in many cases. In fact, very often there are incentives to keep it hidden for various reasons. And so trying to break that open and trying to figure that out and to trace, where power resides, I think is absolutely essential across the board, right? Very good.
I love that power analysis and discussion. And I'll start, and maybe get back to thinking about challenging power and authority. But I would say the initial challenge, and this is back to my experience of HD4 NYC, which is Academic Department of Health Partnership. One of the, every institution has its rules and where their resources go, right? So first figuring out what were the Department of Health rules, for example, around releasing data. And because that was what the partnership was about, was to access the Department of Health data, work with Department of Health employees to get some type of research product or other type of product that would be valuable for advancing a particular issue related to health equity. So just figuring out, others might consider this like the culture of the institution. So just like figuring that stuff out was challenging. And one of the first things I wanted to see was an org chart. And I never got it. Well, it took time to get that, because I was trying to figure out, who should I reach out to in this expertise, in this area, and stuff like that. So just figuring that out. And in the end, it just became important to understand the people that we were partnering with within the Department of Health, who they were, and what they had access to as far as pushing, either any process along as far as getting health data and getting approvals. So after we, had started writing or creating our products or had completed our products, there's multiple levels of approval that we had to go through to even submit something to an academic journal, or even to get our products weren't just, they were policy kind of papers as well that we were producing during this program. Another aspect of it is the changes that occur, in administration and employees. The turnover is a lot greater, within government, and of course you have your regular cycles of turnover with, like your mayors. So even before the George Floyd, I'm interested in marginalization, and who does, when you think about marginalization, it's institutions that have the power to do something and to marginalize people and communities. So in working with this program, I decided to focus on the criminal justice system. And specifically what we were able to do was look at policing and health outcomes. And this was during the de Blasio administration. And I think it was certainly a more, I don't want to say welcoming, but we wouldn't have got as much pushback from the de Blasio administration around looking at policing and health outcomes compared to, well, compared to different administrations.
Be careful, be careful.
Easy. Well, let me say, we were concerned about that because we were wrapping up with our work right before the most recent mayoral election. And so we had a lot of discussions and we were concerned about that. But even during the time of this program, I think it was like 3 years, there was a lot of turnover. Or let me not say a lot. I'll say people were reassigned because there was a national, state, local emergency. So their resources had to go to, addressing issues related to the COVID pandemic. So the two things, like understanding the rules and regulations of a government agency and then, the changes that might occur more frequently within government agencies compared to an academic institution.
Thank you, thank you. You've all added just tremendous pieces of this overall mosaic, and I'm hearing a lot of common themes here, and one of them that has kind of been hinted at along the edges is the role that federalism plays, and federalism is one of these concepts that is often misunderstood, particularly among students very often, but really among large swaths of the American populace, I think at the same time. So this is about the different levels of government, how they work together, how there's sometimes in tension, and how you can get value added from having these different levels. So I wonder if you could speak to, in your experience, how federalism has played a role and whether you see it as having been more constructive and positive, or sometimes a little bit obstructive, as it were, when it comes to really fostering these relationships and furthering your own missions.
Wow, that's a loaded question.
I just looked this way like.
Anyone want to take that? Sorry.
He's giving a lesson here. Right?
Oh, yes. That wasn't in the question.
No,
notes.
Wow. I'm not sure how to best tackle that question, but I will. So let me go back. I think what you're saying is important in terms of federalism. I think what you said, my sister, around this whole civics lesson, like people understanding. When I went to school way back in ancient times, they talked about the levels of government and what and the roles that each level plays, which is shifting as we speak. But it's important to understand how it functions, because at the end of the day, all of these institutions, unless they're completely privately funded, have some stake in government. And so it's important to understand that. It's important to look at when as boring as it is, when the House goes in and they decided the budget for the year, where that money is going, who it's going to, who they slice out of it. There was a social determinants of health budget. That's gone. I don't know if people kind of pay attention to that. And so I don't want to speak too much about government since I'm a government employee, but I will say that in terms of trying to keep track, that the doctor talked about in terms of trying to keep track of who reports to who, how do I get an org chart, how do I get this going, the squeaky wheel gets the oil. If you start to know who the players are and hold them accountable, and again, when we start to talk about public health in particular, most of us are in public health because we care. We're not there to get rich, that's for sure. I'm going to tell you that right up front. We're there because we care. We're there because we consider ourselves public servants and we want to do what's right for community. We are a part of the community, and so we shouldn't be thought of as adversaries, and certainly not all of us are regulators. Public health often is thought of as this regulatory agency. There are things that we want to get done, just like the reason I have the role that I have now is because I really pushed for it. I started in public health many years ago that I told you, and even at the beginning, I understood when I went out, I was in TB control. I went out and I saw that I'm pushing you to take your TB meds so that you don't have to go on some sort of secondary and tertiary harsh regimen. But I'm going into homes where people don't have running water. I was stationed in the South Bronx where people didn't have running water. So I was impacted by that as well. I understood what I was seeing, and I understood the importance of not just focusing on the individual as their disease, but focusing on the circumstances in which they live. How do they manage their disease? The person is not the disease. And so, again, when you talk about, you have to really kind of, unfortunately, separate the different parts of government to really get down to the root of it and to get to what you want. But again, the squeaky wheel gets the oil. If you are seeing something and it's important that you address it, you kind of have to stay in the face of the people that make the decisions about where the funding goes. So I mentioned political determinants of health. I don't want to take responsibility for that phrase. You may have heard of Daniel Dawes. He wrote a whole book on it. Take a look at it. It's really, really good stuff. And while we do in public health and in academia and in healthcare need to focus on social determinants of health, we have to focus on the political intent of the people that make those decisions that impact the social determinants.
That's right. Thank you. Alicia or Asher?
Well, I definitely have to read this book because it just did a light bulb.
It's a terrific read.
Yeah, I have to. I got to catch up. I have to catch up. There's so much to say, and I have to be careful what I say. I've been on both ends of this, and fighting in the New York State Assembly for Downstate, this was our district, for some of the simpler things, it was just so tough. But I think if there was, it's about the advocacy, and I think about walking through the halls of the Capitol and hearing people shout about rent stabilization and homeless issues and drug prevention advocacy, you can name it. But I didn't see when I would be there about, AIDS research or, I can name the plethora of what, we have going on. So we have to be able to teach the community and know that they need to voice those concerns, not just in the doctor's office, and that they have a space to share their needs without it being a consultation. Because right now we just created a Patient and Family Advocacy Council with Dr. Ren Lester here, our Chief Experience Officer. And one of the things we put it together is making sure we had a good core of our patients and their family members, but we had to know who we brought to the room so we can get to what we needed to get to, but still take care of them on a patient relations end, and then teach them what we're doing and understanding our model of we care. It's just like a learning space, and I think we're in a great place to do it. Transport, great. Cancer Symposium, we're doing the work. It's getting the people to come into the room to hear that and then be able to advocate along with us. And our, academia, our doctors are busy, but we also need them to be able to have that time and voice in front of our elected officials and given that core time. And it shouldn't be until something happens, right? Congresswoman Clark, her parents both come to this hospital. So she knows what we do. But I just mentioned the borough president. He's not aware fully until he got a tour. He's like, oh, with 2 small children and seeing how awesome our NICU is, right? It ends up being relational and connects when something is going on with you. So, but we shouldn't have to wait for that, right? It's not watching an episode of Grey's Anatomy and be like, ooh, okay, that's good. Let me check that out. Let me find out if they need that. No, it's like life experiences, but we're dealing with the social determinants of health. Everyone's concerned about everything else. Housing. When I dealt with my constituents, I ran constituent services. The tanty or the grandmother is there. I can see her eyes are bloodshot. Her feet are swollen. She's got high blood pressure, diabetes, all these other things. So on top of that, do you have healthcare coverage? What else do you need? So and that's where the elected officials come in. Between the church and the hospital, we're both serving people. And I know we're talking about government, but the clergy plays a big part in this as well. When you're sick, you go two places. And a lot of people go to the church first. Pray for me. Have you been to the doctor in the last 6 months? Then it's bringing the elected officials to understand the needs on both ends, because they need funding too. And it's to hear my colleague talk about PH directed by funding streams. That, I get it now. I didn't get it. It was a light bulb for me. Understanding how that is really connected. So then that means there's more room at the table for areas of focus, so we are fighting for everything at the same time.
Absolutely.
So I got it, thank you.
You're welcome.
I'll stop there.
You're welcome.
Okay, federalism.
Federalism.
Well, let's go back to that. So
Yeah.
higher levels of, so the ways that government is limited depending on their level.
Absolutely. The
Okay.
tension between them, the way they interact, yeah.
Okay, so actually I was thinking about this on the way here, and just how public health is government, or the history of public health. There's no, and I think, it sounds like there was discussion around this earlier. Like, public health was a mechanism to control populations. And if we think about our foundational tools for public health, biostatistics or statistics, which is about the state, that's what that history, I think the British government was like, okay, we want to know who these people are because we need to get a handle on this.
That's right.
So, these mathematicians, philosophers, whoever, they developed this body, this idea, this thing called statistics, which we train, that's one of the 5 courses that you're required to take in epidemiology. So those are friends. So we, as a School of Public Health, are training people to do that work within government, to count, manage populations. And then, an extension of that, I often think about, like, even if we're NIH funded, is that like a government
It is.
academic
Absolutely.
partnership?
Yep. Yeah, absolutely.
So the ways, some of our choices about what we decide to study can be influenced by those funding streams. So what Congress or the federal government prioritizes, I know Jill Biden is going to be over an effort. There's already been work on this area, so I'm trying to figure this out, but it's a whole additional focus on women's health.
Yep.
So.
Just announced this week.
Yes,
Yeah.
yeah, so as academics in schools of public health, and we know to get promotion, to get tenure and promotion, we have to get these funding streams, we have to be awarded those funding streams. So, and thinking about the way that these resources can be, influence what we decide to do in academia or the research we decide to do. So that's my federalism kind of thinking around this.
And you point to the fact that really, particularly in public health, there's no getting around working with government.
Yes.
We may think that, we're at different ends, but in effect, we're working together, really every step of the way. Sometimes we just don't realize or recognize it as such. So thank you for putting words to that.
I just want to say one more thing, because yes, we're focusing on the funding, and that's important. But we also need to pay attention to what's coming up in federal government, because there was a bill that was proposed very recently that talked about eliminating DEI in the medical schools. And so how do we move forward? I mean, I'm not sure. I know why the attack is happening on DEI, but I'm not sure how we expect things to change if we don't. There should be some prevention strategy, right? And so if we start in the medical schools, or even before the medical schools, talking about DEI, including folks that don't look like mainstream folks that make the decision, And considering some of the things just that Dr. Morse just talked about, if we don't do that, how do we move forward? How do we move forward as a country? Because I think what we forget is that what impacts the least of us impacts all of us. If we didn't learn anything else during COVID, we learned that. We learned that the people that delivered our food and kept us safe for those of us that were able to work from home suffered. We learned that the folks that drove the trains and the buses and all the rest of it. And so we can try and ignore or continue to try and ignore what's happening, but it's going to impact all of us at the end of the day. And so I think, yes, the funding is absolutely important. It is crucial to keep these things that we have now running, but it's also important to really look at what's happening in federal government in terms of the attack on DEI, health equity, social determinants of health, and to voice our concerns about that.
Absolutely. Very good. So we have a few minutes before I want to open it up to questions in the audience here. And so, you know, I just, as a final non-question question, I suppose, is there a question you wish you were asked that, you know, you'd like to answer now, or just some final few words that you'd like to put out there before we open it up to the wider audience? Want to start over here with Azure maybe this time?
Well, there was a question, what strategies can be employed to ensure long-term sustainability and impact of academic government collaborative projects? And I was like, I don't have an answer for that. But maybe in not having an answer for that, that is the answer that we, you know, as academics have to be ready. You know, we have areas of expertise and we're building on that. And we have to be ready for our moments, you know, so, and to be, from my perspective, if you are working with government, be prepared for flux and change and, you know, all the dynamics of that can occur when you are working with government partners.
Thank you. Alicia?
Just to piggyback on that, I have a lot to say about community engagement. That's where I thrive and love and work with the likes of Dr. Marshall and Nurse Betty Jung here in their work in patient education. They have a longer name for the group, but everyone knows who I'm talking about when I mention them. And doing the health fairs, community fairs, the NYP community baby showers, that access. So what I started to do is reach out to students that I'll bump into. Are you available? Just a table. To see what's out there. More in community engagement. I know that like pediatric Dr. Christina Guillaume works with, that's my sis right there, with her students, and they do a food giveaway with a local school. I'm so big about being outside. I know it's like a thing word now on TikTok, like outside, like we need to be outside. Like, we should be all going outside and doing surveys. And I talked about that last year. That's the only way we're going to understand what the needs are of the people, besides what's hurting. Because what is also hurting is them not being able to communicate. Them, the community, our youth, our kids. So I think having those pieces, giving voice, we have a ton of auxiliary organizations that our young people here on campus have, tuning into them. What are they doing? Not just for a specialized month like Black History Month and, you know, Daniel Hale is getting together, like bringing everyone out and saying, what are you guys doing? How can we help? Who do you need to connect to? So, and that's what I'm trying to develop with my department, not just the advocacy part, but giving the access so they understand your role. Like I want to do lunch and learns and bring them in to meet you. We don't know who wants to do what until you have a conversation with them. So when the SYP kids come in here, 150 every year, I'm one of the speakers to find out who wants to be in healthcare. And a lot of the young people that come do want to work in some aspect. And what I try to do then, try to connect them to Dr. Camille Clear, who wants to do OBGYN. Connect them now, I need to grab you. Can I induct you as well? Like, that's what we have to do, literally. I see Dr. Fablé in the room. Like, these are the people that I watch doing symposiums on maternal health. and having those discussions, and then learning about what she's doing and the grant she's worked on. Once again, grant funding, but who knows about it? What does she need? So it's just, we have to just talk more, not just high in the hallway. What do we all need to get to the next step? And collaboration is important. So when I started here, when I spoke at the Impact 2030, I said, I want to break through the silos. Get out the silos, let's jump in the pool together and get the work done.
You sent us a question ahead of time that was said, what would you say are some of the biggest mutual misperceptions that can impede collaboration between academia and government? And I would say that one of the biggest misconceptions, I've talked about it a little bit here, or I've alluded to it, is commitment. I think that because of the funding, because of the sometimes seemingly opposing views, folks think that government is not committed to working with academia, but that's not true. Again, we're in public health for a reason. And I'm specifying public health as opposed to any other part of government. We're in public health for a reason. Most of us are there because we want to make things better. We want to be of service to community. And so there is that commitment. And I think, on the same side, on my side, sometimes we don't feel the commitment from academia to partner together. So I think that it's just kind of a matter of what we just said, talking and making sure that we have a conversation, that we come to some mutual agreement, and we commit to moving forward together.
Talking and breaking down those silos, absolutely. Very good. All right, so we have time for a question or two from the audience. I think there are roving microphones somewhere. If anyone has a question out there for the panel.
Oh, this one.
Over here. Could you just speak up, or we have a microphone, I think, coming your way. There we go. Great. Excellent.
Hello, thank you guys so much. It was really informative. I just wanted to get the name of the book that you had mentioned earlier, because I want to read it.
It's called Political Determinants of Health. It's by Daniel Dawes. His last name is spelled D-A-W-E-S, and I hope he'll give me a shout out for.
Yeah, it's very well done. Very well done. Absolutely. Great. Other questions from the audience? Right over here. Yeah.
Hi. Thank you guys so much for such a great panel. It's really reassuring to see that there are clearly people in government who are committed to building these bridges and know what's going on and what needs to be addressed. I guess what I wanted to ask, and what would be, I think, productive to think about is, from your expert perspectives and inside knowledge, who would you recommend to us to be putting pressure on to start making headway and opening up more flows of funding to actually address the things that need to be changed in government?
Great question.
That's a great question.
Yeah.
That's a future activist right there. It's like, put pressure. And that's exactly what needs to be done. It depends on your area of focus, knowing what, it's easy to say, I could give you names, but what is your, what's the area? And then I can say, I can point you to that person. So it's just knowing also like who in every house does what. So like for instance, Senator Rivera is the chair of the health committee. Amy Paul, we can go into that. So it's knowing who chairs what, writing, letters and emails still are work. Us waiting to be in a room, pushing that envelope, writing to our elected officials, knowing who your elected officials are also is important. So it's about what area. You never know who is focused on what bills there are. Literally, you can Google in New York State and put something in it. There may be a bill that covers that. They just released, they're putting out a bill, Senator Rivera, along with Assemblymember Joanne Steinman, to push for the mandate for community engagement in the review of hospital closures. But why do you think that came up? Because another situation is going on. So literally, it's just, Google is your friend, and knowing what area. So whatever that focus is, then we can point it. That's just one way of saying it. But it's just knowing who reports to who's doing what, and then going for it. And advocacy can happen in so many ways. There are people going up to Albany and to DC to express their opinions, and social media, email, and each elected official has a district office, and they have a health policy person. So that's another key thing to know as well.
Get to know the staff members.
Yes,
I often
they
try to
could be your
explain in my
friends.
classes that we're often almost distracted by, the power of the elected officials themselves, but the staff members are the area experts.
Yes.
They're the intelligence on the ground, and they have that politician's ear very often.
Yes.
So that's where a lot of the power resides. So
Yes.
important to consider that as well.
Yeah, they feed the information. There's no way they could do everything. They're dealing with housing, health, so they depend on their staff, just like Dr. Salafu depends on Dr. Straker and Lakia. You need all those people to give that piece so they can know exactly what they're talking about. You don't want someone that's just sitting there and just like off the top of their head. They have the experts behind them to help them with that information and data.
And participate in your community board.
Oh, yes.
I've said that on the last panel, but that's a
right.
good level of entry.
Yes.
Yeah, and I
So
would
I'm
also
not on your panel, but be registered to vote.
Yes, thank you.
I
Yes.
I would also say that whenever you have the opportunity, believe it or not, it's not always about complaining. Sometimes it's about sharing your successes. Sometimes these individuals want to hear individual success stories. Send the success story of an encounter you had at this institution that was positive, that changed your life in some way, and those are wins for them. And that way they can, if they're already on your side, that's just more ammunition for them to advocate for you.
Yes, good and bad testimonies are needed in anything. That's what Yelp does for businesses. It's the same idea. Same idea.
Very good. Well, we are just over the 10:45 mark, so I suppose we should move into our break next. But before we do, I want to thank our panelists once again, Louise Square, Alicia Goodridge, and Dr. Azure Thompson.